few years ago, we had the first data come out relating to the use of PARP inhibitors, namely olaparib and then talazoparib for patients with germline BRCA1 or 2 mutations in metastatic breast cancer. Interestingly, both studies demonstrated an improvement in progression-free survival of around 3 months with the use of single-agent PARP inhibitor compared to treatment of physician's choice, which would be single-agent non-platinum chemotherapy. In general, PARP inhibitors are well tolerated. Both studies showed good quality of life or patient-reported outcomes associated with or in favor of the PARP inhibitor. And so these drugs are now available to us for patients who have germline BRCA-mutated breast cancer. Well, a number of people have questioned whether or not we could utilize PARP inhibitors in patients whose tumors have other mutations that are along the DNA repair pathway, RAD51, for example, PALB2, etc. And there have even been some assays developed to look at homologous repair deficiency, so just sort of classifying the patient as having a deficiency in the ability to perform homologous repair well. And there hasn't been a whole lot of data to date to support the use of PARP inhibitors in that setting, although there's a lot of theories of why that would work. At ASCO in 2020, Priyanka Sharma and colleagues presented a SWOG study which looked at the combination of another PARP inhibitor, veliparib, in combination with cisplatin versus cisplatin plus placebo. It was a phase 2 clinical trial, and she actually showed that those patients who received the PARP inhibitor who had homologous recombination deficiency appeared to benefit from the use of the PARP inhibitor in combination with the platinum chemotherapy. So this is the first real inkling that we are getting that these types of drugs might work in tumors that are not just restricted to germline BRCA mutations. Other investigators are looking at whether these agents are beneficial in tumors that have somatic mutations in BRCA or in homologous recombination, and I think this is going to be a very interesting area for us to see whether or not these agents have effectiveness in that realm. The nice thing about these drugs is they're non-chemo, and they're generally better tolerated than chemotherapy, and so for patients with triple negative breast cancer and one of these mutations, it would be nice to add to our armamentarium and have a drug like this to use. Outside of a clinical trial, I'm not yet compelled to use these drugs in a patient with one of these mutations. My preference would be to find a clinical trial for them, nor are these being used yet as standard of care in the early stage setting. There are studies, large studies ongoing that we're waiting to report out to tell us whether the use of these agents in the adjuvant or neoadjuvant setting will benefit patients. So it's an exciting time. I'm looking forward to seeing some of these results report out.